Welcome everyone. My thesis title is Treatment-Related Cardiotoxicity in Pediatric Oncology. My name is Nóra Beke. I'm a PhD student. My first project title is Comparing the Diagnostic Tool's Accuracy for Early Detection of Cardiac Failure in Pediatric Oncology. This will be a systematic review and meta-analysis. Although the 5-year overall survival of children with cancer is 80%, we pay a heavy price for it because of the serious cardiotoxic side effect of the treatment. Cardiovascular diseases are the leading cause of late morbidity and mortality. Current guidelines suggest echocardiography for monitoring, but in many cases it does not detect early enough. Otherwise, we know several other screening modalities, for example, other imaging techniques, blood biomarkers, genetic variants, and microRNA. But so far, there is no study that compares their accuracy. Therefore, our study aim is to find out which modality is the most accurate in detection of cardiotoxicity. Our clinical question is, what is the most accurate prognostic tool for predicting therapy-related cardiotoxicity in childhood cancer patients? We use PFO framework. The population is children with cancer and childhood cancer survivors. The prognostic factors are cardiac biomarkers, echo, genetic variants, microRNA, and the outcome will be the prediction accuracy of heart failure. Our hypothesis is that echocardiography is the most accurate prognostic tool in detection of therapy-related cardiotoxicity in childhood cancer patients. My search key contains 4 domains, and the hit numbers can be found on the top of the slide. After the systematic search, I had 5,000 articles, and at the end of the selection phases, I had 73 eligible articles. Based on the type of the predictive factors, we divided the articles into 5 major groups: microRNA, echocardiography, AI model, serum biomarker, and genetic variants. The outcome is these factors: prediction performance measured by area under the curve, correlation, odds ratio, adjusted odds ratio, and mean difference. In this first forest plot, we have summarized some predictive factors. In this case, they are investigated in a complex prediction model built by AI. We have plotted the time-independent performance of these following models. We use area under the curve as a unit, which shows the quality of prognostic ability of these prediction models. Area under the curve is a region under the receiver operating characteristics curve, which shows that as we change the underlying continuous variable, the sensitivity and specificity also change. The value can be varied between 0.5 and 1. 1 represents the maximum sensitivity and specificity, and 0.5 represents the result of random guessing. We used 3 cohort studies, and the heterogeneity here arises from the differences in the prediction models. We use the state-of-the-art values. The overall AUC value is 0.8, but we can see that ECG with clinical parameter reached 0.89 AUC value, which is an exceptionally high value. This result suggests that clinical parameters alone are not enough. Additional examinations are definitely needed, and even then, we cannot reach outstandingly good performance. In the next forest plot, we can see the prediction performance of some microRNA and high-sensitivity cardiac troponin T. In this case, we couldn't pull the results because statistically it was not possible. The time represents that how many hours after the chemotherapy they check the microRNA level. We use area under the curve as a unit, and we use 2 cohort studies, the AUC values are high. They can reach up to 0.9 AUC value. And overall, this suggests that microRNA could be a promising predictive factor, but further studies and larger sample size need to prove it. In the next forest plot, we can see the prediction performances of NT-proBNP and cardiac troponin T. We use sensitivity and specificity as a unit. Sensitivity means the success rate of the diagnostic procedure among patients with cardiotoxicity, and the specificity means the success rate of the diagnostic procedure among patients without cardiotoxicity. We used 5 studies. One is a prospective study, and the others are cross-sectional studies. In the case of NT-proBNP, we couldn't put the results because of the diversity of the threshold, but we can see that both sensitivity and specificity vary between a very wide range. And in the case of troponin, using the 0.01 threshold, the sensitivity is low and specificity is high, which means that troponin rather correctly identify patients without cardiotoxicity than with cardiotoxicity. And these results suggest that nor cardiac troponin T and nor NT-proBNP achieved outstandingly good performance. Our study main strength is we try to create order in a chaos caused by a non-uniform publication strategy of the articles. This will be a complex and comprehensive analysis. Most of the predictive factors we have known so far. Our study main limitations are incomplete data provision and the diversity of the variables and definitions. That's why we couldn't put the results in most of the cases. Our study conclusion is the detection of cardiac failure in pediatric oncology can be achieved with AI prediction models. Our main implication for practice that AI prediction models and microRNA should be used in diagnostics. And the implication for research is that appropriate control groups are required, and development of multivariate AI-based models could be a new way for improved detection of cardiotoxicity. Currently, I'm in the manuscript writing phase. I wrote the methods part. My second project title is investigating the side effects of tyrosine kinase inhibitor in pediatric cancer patients. This will be a systematic review and meta-analysis. One of the most promising groups in targeted therapy are tyrosine kinase inhibitor. These drugs work by tyrosine kinase enzyme, so they affect gene transcription and DNA synthesis. Patients often receive them for years. That's why very important to know what their long-term side effects profile. The major groups of side effects, what they can cause are cardiotoxicity, hepatotoxicity, endocrinopathies, and growth retardation. However, so far there's no comprehensive study about these effects. Therefore, our study aim is to provide evidence of what side effects can be expected in the long term. Our clinical question is what are the long-term side effects of tyrosine kinase inhibitor in pediatric oncology patients. We use PICO framework. The population is pediatric cancer patients. The intervention group is chemotherapy with tyrosine kinase inhibitor. The comparison group is chemotherapy without tyrosine kinase inhibitor, and the outcome will be the side effects. Our hypothesis is that the use of tyrosine kinase inhibitor during chemotherapy does not increase the risk for hepatotoxicity, cardiotoxicity, endocrinopathy in pediatric cancer patients. Our study clinical implication is give better disease outcome for the patients, provide evidence regarding its long-term effect, and clinicians could make preventive intervention in time. Since my vision is that pediatric cancer patients should live high-quality life without any complication, I would like to support this with my two study. I would like to end my presentation with the words of Ralph Waldo Emerson: all is a riddle and Cato riddle is another riddle. Thank you for your attention.
All right. Thank you very much. Thank you for keeping the time so well, so we will have a long time to discuss your topic. So before we start the discussion, I have one question related to the first topic you had. So I don't really understand, but most probably you have a strategy for that. How the treatment of these patients will change if you can predict they will have cardiotoxicity at the end? So can you somehow intervene earlier to prevent it in the future?
Yes, I think with the most accurate and most earlier screening tools, we could make preventive intervention time, and we can monitor this patient more often.
Right, I have some questions. Did you extract the chemotherapy type in your first project? Like what kind of chemotherapy these patients are receiving?
Yeah, we extracted this data, but most of the articles mention that they use anthracycline. So it's a major group, so we couldn't make subgroups based on chemotherapy type.
And do you think if you can predict the cardiac abnormalities earlier, you can change the chemotherapy type they are receiving?
I think no, the chemotherapy type, rather the dose of the chemotherapy.
The dose.
Yes.
Mm-hmm. All right. And in one of your plots, I'm not sure if I saw correctly, but the specificity of one study was 0.
Yeah.
Did you investigate what happened in that study in the pro-BNB's plot?
Okay.
The first one and the second subgroup.
Yes.
Yeah.
Good question. We don't know, but we will examine what's the problem about this study.